We're going to talk about today rheumatologic manifestations in diabetes. I have no conflicts of interest to declare. The learning objectives are here. My motivation comes from basically a lot of the grand rounds that I do result from what I see in the clinics and on the wards. Rheumatologic problems that are associated with diabetes are often undiagnosed in the clinic. Not so much misdiagnosed, but undiagnosed, or we fail to make the association between the bone and joint or musculoskeletal manifestation and how diabetes contributes to it. So I've got house staff here, so instead of me going over this with you one by one or one-on-one, I've got some of you here that are a captive audience, and so you get to hear the same sermon all at one time. When I was in medical school here a long time ago, we always thought about diabetes as just being aberrant carbohydrate metabolism, either the absence of insulin in type 1s or ineffective or unutilized insulin, excessive unutilized insulin in type 2s. Then we became more aware of the microvascular complications, the big three, which is nephropathy, neuropathy, and retinopathy. Then we begin focusing on the macrovascular complications like cardiovascular and cerebrovascular disease. And just recently, I think we've been paying more attention to the musculoskeletal problems that diabetics have. And it's important to look at because it compounds the functional impact that other complications have. For example, if you have a diabetic with peripheral neuropathy and they have some of the musculoskeletal complications that diabetics can get, it impacts their functional ability even more, sometimes not additively, but even synergistically. And what I'd like to do here today is to get you guys to thinking about these problems earlier, initiating treatment earlier, and so we can educate the patients about the problems that they're developing that may be related to their diabetes. Now, these are things that are very much more common in diabetics than non-diabetics. Adhesive capsulitis of the shoulder or frozen shoulder. Possibly frozen hip, which is not very common but being reported, Dupuytren's contractures, hyperostosis, and then shoulder-hand syndrome. Now, there are other complications that are seen in increased numbers or increased rates in diabetics, things that are much more, we see much more often that we don't make the association between these conditions and diabetes. And then, even more importantly to me are what I call the mimickers. These are things that can look very much like other conditions and can even be misdiagnosed or undiagnosed because we don't think about these conditions being in diabetics. And I'm going to spend some time on those today. So let's start looking at adhesive capsulitis of the shoulder. This is one of the more common things that we see in the clinic with our diabetic patients. It's a diffuse shoulder pain. It causes loss of range of motion in all planes, abduction, adduction, flexion, extension, internal, external rotation. There's little to no evidence of intra-articular disease in these patients. Quite frankly, most of them earlier on will have rotator cuff impingement. And diabetics tend to get impingement at earlier ages. Also, there are certain occupations that are predisposed to impingement frozen shoulders, such as carpenters, drywall hangers, painters, etc. Anybody that has to work repetitively with their arms over their heads are prone to get impingement and progress to frozen shoulder. In the MRI, you see thickening of the joint capsule, and there can even be adherence to the humeral head. As you can see, it's 4 times more common in diabetics than non-diabetics. If you think about 11% of diabetics, think about how many diabetics we see in the clinic. And there are probably patients that are walking or coming through our clinic every day that have frozen shoulder, and they may not know it or they may not tell us about it. It's seen in 28% of people with an abnormal oral glucose tolerance test. And the thing I want you to remember about this is you're going to see this in pre-diabetics. And it brings up something else that we see in diabetics. Oftentimes these complications begin before the diabetes becomes clinically obvious. There's a lead time involved from the time that the metabolic derangements of diabetes begin and affect the tissues to the time that the patient becomes overtly diabetic. How many of you have seen a type 2 diabetic at new diagnosis already have microalbuminuria or neuropathy It does happen, and we need to start thinking about these problems in pre-diabetics or patients who we think may be at risk for diabetes. Now, this used to be much more common in type 1s than type 2s. But it can be in both. You can see here, study in 96, it was twice as common in type 2s, but in 86, it was pretty much equal. The longer a type 1, there's an association between age and type 1 and type 2. They tend to get this earlier. Diabetics tend to get adhesive capsulitis at earlier ages than non-diabetics. The duration of the disease, longer duration of disease, tends to make it more common in type 1s. So how do you treat it? The goal is to restore range of motion. PT is essential. A lot of patients will get a cortisone shot and not go to PT. I can tell you in my private practice, I would not give somebody a cortisone shot if they wouldn't go to PT. They have to go to physical therapy. The earlier the better. Multiple modalities are used. As I said, you can use pain relief with a corticosteroid injection. If a patient does not respond to conservative treatment, there are two surgical options. The old surgical option is to put the patient to sleep and manipulate the shoulder under general anesthetic, and basically the orthopedic surgeon just takes it and rolls it around and breaks up the adhesions. And the reason you put them to sleep is because it hurts. There are complications, including proximal humerus fracture. In a patient who has severe osteopenia or someone who's had a recent fracture, you can refracture the humerus. That you can dislocate the joint, the glenohumeral joint. You can also get actually a nerve injury. It tends to be temporary. But you can get temporary weakness in the shoulder girdle muscles. The more modern modality that's being used in some centers is they put the patient to sleep, go in with an arthroscope, and basically buzz or burn the adhesions. They go all 360 degrees around the humeral head and the capsule and buzz the adhesions or burn them loose. Now, it takes more time, it's more labor intensive, it's probably more expensive, but you don't get the risk of injury to the humerus, fracture of the clavicle, all the other things that can happen with manipulation. When you see a patient who has adhesive capsulitis, the one thing you need to tell them is this is going to be a long course of therapy. Typically, it can last, pre-surgery can last 6 months, just to try to establish range of motion. After 6 months, if it doesn't work, then you refer for surgery. The patient then has to go post-op physical therapy to maintain range of motion and reestablish its strength in the shoulder girdles. So when you see a patient with adhesive capsulitis, the one thing you need to tell them is it can be 12 months or more, and even in that, the outcome of therapy can be suboptimal. So you have to prepare them for that as they go into it so they don't have unrealistic expectations. Now, I don't see a lot of shoulder-hand syndrome. It may mean I've just been missing it, but shoulder-hand syndrome is basically frozen shoulder paired with swelling, tenderness, and vasomotor instability in the hand, and the type of thing you see in the hand is like reflex sympathetic dystrophy or Sudeck's atrophy. The other thing to remember is pain is disproportionate to the physical exam. The patient will complain vehemently of pain even when the hand itself may not look that bad. And there are 3 stages which you can see here. And I've got to tell you, if you're going to diagnose somebody with reflex sympathetic dystrophy, they call it complex regional pain syndrome, Sudeck's atrophy, you really need to see all of this. You need to see the tenderness, the vasomotor changes, the temperature and color changes, the shiny skin, the subacute atrophy. You need to see that at every step along the way, because if you don't, you're probably going to misdiagnose a patient and put them at risk for a lot of things that may not help them and may even hurt them. It's present in 7.5% of diabetics. When you image it, you're going to see patchy osteopenia on plain films. Bone density, you can see up to a loss of 1/3 of the bone mass, and that's probably related just to long-term disuse or lack of use. You can do a 3-phase bone scan, which shows increased blood flow in the area of the bone itself in phases 1 and 2, and then the uptake increases in the periarticular tissues in phase 3 of the scan. And that's pretty much diagnostic. The treatment's not very gratifying. Analgesia, range of motion to maintain range of motion so they don't get contractures and weakness. Now, we don't typically give diabetic systemic glucocorticoids. So when a diabetic has shoulder-hand syndrome, we usually progress to a sympathetic block. And then the last line of defense is to do a sympathectomy. This is not all that common. Now, this is one that's a great mimicker, and I want to spend some time on this because I do think we see this in clinic and we miss it. It's called a lot of things: Neuroarthropathy, stiff hand syndrome, diabetic stiff hand, syndrome of limited joint mobility. It's seen in both type 1s and type 2s. It's more common in type 1s. Longer duration disease makes it more likely. Their prevalence ranges are all over the place, but most studies center at about 35%. Think about the diabetics, how many diabetics we see in clinic. Think about how many diabetics we see in clinic that we think have peripheral neuropathy or compressive neuropathy, and you can begin to get an idea of how much of this we may be missing. Now, clinical features. This is largely a diagnosis of exclusion. The patients will complain of stiffness, loss of dexterity, and weakness, which sounds like what? It sounds like an inflammatory arthritis or peripheral neuropathy or compressive neuropathy, right? But the physical findings will tip it off. They tend to have thick, tight, waxy skin, which is called sclerodactyly. They can have synovial thickening or fusiform deformity in the joints and the interphalangeal joints. And they lack full range of motion, particularly extension. And that's called a positive prayer sign, and I've got some pictures of that. They especially lack full range of motion, the PIPs and MCPs. They also lack full flexion, and I've got a picture of that coming up. It's one of the mimickers because it can mimic inflammatory arthritis. It can mimic and coexist with peripheral and compressive neuropathies like carpal tunnel. Now, think about that. Why is that important? If you've got a diabetic who has other diabetic complication of the hand like compressive or peripheral neuropathy, and you also diagnose them with diabetic hand syndrome, and the patient says, well, can he release my carpal tunnel? You can say, yes, we can do that. You send the patient to the hand surgeon, he releases the carpal tunnel. The patient doesn't get full recovery, comes back to you and says, goes to the orthopedic surgeon and says, my hand is no better. Orthopedic surgeon says, well, I fixed your carpal tunnel, go back and see your primary care. So you may be left the one trying to explain why the patient didn't get a very good result from surgery or decompression. Now, it can also be associated and seen in conjunction with interstitial lung disease, and that's an important association to make. Patients can come in with shortness of breath. How many diabetics in our clinic do we see short of breath? How many diabetics in the clinic do we not see short of breath? So if you've got a patient who has diabetic hand syndrome, you also need to think about interstitial lung disease. Now, this is a picture of a type 1 of about 40 years duration. Since it goes back 40 years, back to the time when Dr. Levine and Dr. Greenberg and I were practicing without A1Cs, and up to a point without finger sticks. Boy, those were the good old days. So for the first 15 or 20 years this patient was diabetic, there were no A1Cs. We had no idea what the blood sugars were except what they drew in the office, and she was followed with urine ketones and glucoses. But for the last 20 years, she's been in a pretty decent control with pretty good A1Cs. If you look at this, I'll try to show you, you can see right here that joint is somewhat fusiform, as is this one. You see kind of the waxy appearance with the loss of wrinkles. That's sclerodactyly. And you can see some fusiform changes here. So that shows you some of the features of diabetic hand syndrome. Here's another one. This is a positive prayer sign, the same patient. You can see that she is unable to fully extend her fingers. Oftentimes you'll see them and they'll put their fingers and they will intersperse or interdigitate. So lacks full extension. She also lacks full flexion. If you look at this, especially on the right hand, she can't fully flex the fingers of her right hand. And this diabetic also has peripheral neuropathy and has had bilateral carpal tunnel releases. So you can imagine the functional impact of this problem this has had. Now, cause. You get dermal, if you do biopsies, you see dermal and subcutaneous sclerosis of the tissue. It shows increased dermal fibrosis with increased collagen deposition and loss of normal function or structures. And there are theories involving increased cross-linking of collagen, increased resistance to collagenase, In other words, the collagen fibers get stuck together tightly. There's also non-enzymatic glycosylation, which goes along with poor control, which leads to increased cross-linking. And additionally, possible increasing hydration, swelling of the connective tissue. Probably Dr. Greenberg and Levine and I, maybe Dr. Todd are the only ones that remember an aldose reductase inhibitor. Remember that? They were put out in the 80s, I guess, as a possible treatment for diabetic neuropathy. They fell out because they caused excessive side effects and were consistently effective. But we think the aldose reductase pathway might have a role in causing diabetic hand syndrome and the thickening of the tissue. Also, advanced glycosylated end product can be deposited due to the enhanced availability of glucose, which goes along with poor metabolic control. How do you treat it? Well, there's not much you can do. The best thing to do is try to keep the patient under better control longer. You can do dynamic splinting, you can do OT to increase range of motion or maintain range of motion. Non-steroidals and analgesics. The main thing to do here is make the diagnosis as quickly as you can so that the patient doesn't go along for years with what turns out to be diabetic hand syndrome. There was one study 30 plus years ago that suggested improved glycemic control led to reduced skin thickening, but it was using the old, I guess, first generation insulin pumps, which were pretty cumbersome. And I couldn't find any more recent studies on tightly controlled diabetics on insulin pumps with this. Along the same lines, we've got Dupuytren contractures. They're focal. They tend to cause thickening in the palmar fascia, much like the thickening you see in diabetic hand. Most commonly in third, fourth, and fifth digits. 25% of patients with this have diabetes. Up to 63% of diabetics will have Dupuytren's contracture, which is probably 2 to 3 times the incidence of the general population. And it's caused by proliferation in the tendon sheath versus altered collagen deposition, much like diabetic hand syndrome, which kind of suggests a similar pathway. And there doesn't seem to be any linkage to trend. In other words, well-controlled diabetics seem to get this just as much as poorly controlled diabetics. The treatment includes physical therapy, again with splinting and maintenance of function, non-steroidals and analgesics. You can put a low-dose corticosteroid injection in the tendon sheath, being careful not to inject it into the tendon, and they can undergo surgical release by a hand surgeon. Now, neuroarthropathy, also known as Charcot's. This is not just seen in diabetes, but it's also seen in syphilis and syringomyelia. The difference is, in those two conditions, the predilection is for the knee and the upper extremity, whereas in diabetes, it's the ankle and the foot. The wrist, elbow, and shoulder are rare in diabetics. So the clinical features usually, and again, this is another great mimicker that we'll talk about as we go along. Usually follows minor trauma which the patient may not be aware of, especially if they have neuropathy. So the patient will come in with an acutely swollen foot. They may or may not be able to tell you how they got it in the first place. The pain also seems to be disproportionate to the history. Again, if they have neuropathy, they can't really tell you when it happened, so you don't get the history of trauma. Rocker soles. By the time a patient gets a rocker sole, they've usually had several episodes of this. Rocker sole means instead of the arch, the convexity being upward, the convexity is reversed and downward. Occasionally they'll come in with redness and edema and crepitus. So if you see a patient who has a red swollen arch, what do you think about? Gout, right? That's at the top of your differential. If it's a diabetic, you need to think about the possibility that this is an acute Charcot's foot. And it can mimic gout, but again, inflammatory markers are normal. The patient can have a mildly erythematous foot and even have some tenderness, but the SED rate will be normal or not elevated enough to call it gout. There's no fever, there's no leukocytosis. The x-rays can show joint space disruption, narrowing, and some disorganized sclerosis of the cuboidal bones of the arches. Possible mechanism. I started to put a really pretty picture here, but basically, to make it simple, rank and rate ligand complex is something called osteopintegrin. Bottom line is they release cytokines and other local inflammatory mediators. There is an inflammatory component to this. And the end result of that is they activate osteolysis locally, and that's what produces the X-ray changes you see and produces the acute onset of the condition. Treatment is very ungratifying again. It's best when it's diagnosed early. Oftentimes, as I said, the patient doesn't come in, they're not aware something is wrong, or they have been misdiagnosed with gout over the years when they've actually had multiple episodes of Charcot's. And if it keeps recurring and the foot becomes further deformed, it can be disabling. You think about a patient or someone who spends all their day on their feet, and they've got rocker soles, they've got reversed arches, they're not wearing diabetic shoes, they don't get custom orthotics. This is the setup for a foot ulcer in these patients. It can have a significant vocational impact. So what you want to do is try to keep the patient from getting to that point. And part of that is educating the patient about their feet when you diagnose them. It's not enough just to do a foot exam and tell them you need to watch your feet. We need to tell them if you have acute pain in your foot, get in to see me so I can look at it. The options for treatment, though, plaster cast. How many of you have ever seen a diabetic wear a plaster cast for 12 to 18 months? A non-removable plaster cast, that is the most effective treatment. It's better than complete non-weight bearing is better than incomplete non-weight bearing. 12 to 18 months in a cast. Partial non-bearing using patellar tendon bearing orthotics, which means there's a lift in the heel to shift weight bearing, some of the weight bearing off the patella and onto the forefoot, works, but it's not as good as prolonged non-weight bearing. The specially fitted and molded orthotics can be used after the acute treatment to better redistribute the weight. Rarely surgical arthrodesis. Let's see, Dr. Levine, there was a chief resident here when I was a medical student named Jim Wade. And Jim had Wade's rules of surgery, and one of them was never mess with a diabetic's foot. So I don't know how much surgical arthrodesis we do with this, but I haven't seen it done very rarely. There have been some infusions of bisphosphonates that seems to maybe help acutely, but it doesn't seem to be a long-term fix. Now, hyperostosis. Disseminated idiopathic skeletal hyperostosis is one of these. It is much more common in diabetics, and we don't think about it very much. It can be over 20% in women and patients 60 to 69. There's no association between A1Cs over the long run in DISH. There's also an association between obesity and hyperostosis, which isn't surprising because a lot of obese patients have hyperinsulinemia. And there's a link between increased insulin levels and insulin-like growth factors. If you think about it, those are anabolic hormones. In other words, anabolic hormones produce or promote deposition of tissue, mostly adipose, but it can also cause excessive deposition of bone. The clinical features, they tend to have mild back pain and stiffness, but the range of motion will be preserved because this is a disease that usually affects the anterior part of the spine. The more flexible, movable posterior elements are not involved. It's non-inflammatory. If you think about somebody that you think may have ankylosing spondylitis, they're not going to have inflammatory arthritis symptoms like prolonged early morning stiffness. It's not present here. The stiffness in this tends to be pretty much around the clock, and it doesn't change during the day. Now what you see is osteophytes that extend along the anterolateral surface of the vertebral bodies is more often on the right. The osteophyte formation is also disproportionate to any changes in the intervertebral disc. And as a matter of fact, if you see osteophytes, multi-level osteophytes, particularly the thoracic spine, and the disc spaces are preserved, you probably got DISH. Even if you see DISH changes, let's say you have somebody that also has degenerative disc disease, the osteophytes are going to be far out of proportion to the disc space narrowing. They can also occur internally, i.e. in the spinal canal. You can get symptoms of spinal stenosis. And this also tends to be more common in thoracic spine. So if you have somebody who has a level, neurological level of spinal stenosis that seems to be cervical, it may be DISH. Also, you can see extensive disease in the cervical spine that causes esophageal compression and dysphagia. And actually, I saw a case of this about 2 or 3 years ago with telemedicine with somebody that had dysphagia, and we got an upper GI, and on the spine part of the upper GI, you could see these huge thick bridging osteophytes, and his disc spaces were preserved. This gentleman had DISH. Here's an x-ray of somebody with DISH. And what you're going to see here, and again, the predilection is for the right. You see this. Here are these bridging osteophytes here. Particularly you see them here, multiple levels. If you go over here and look, you can see here they are here, 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 and here. Look at the disc spaces. They're not that narrow. They look pretty normal. So you have osteophyte formation that is greatly excessive when you look at the degree of disease the patient has. This is actually a 3D cervical, or probably spine reconstruction by CT, and this shows these thick bridging osteophytes on the right anterior lateral surface. You can't really tell about the disc spaces on an AP view like this, but you can see that at least some of these appear very normal. But you've got these dense osteophytes on the right anterior lateral spine, and that's pretty typical of DISH. Now, one other type of hyperostosis you can see is Hyperostosis Frontalis. It can be external or internal. The internal type is usually seen on CTs when you're working up another problem. They typically are not severe enough to cause compressive symptoms. I have seen one case of Hyperostosis Frontalis externa on a consult in the ICU. Anybody ever watch the old Addams Family? Lurch. Lurch has the big supraorbital ridges. That's Hyperostosis Frontalis externa. If you've seen Young Frankenstein, Peter Boyle's character has it. It's a sign that you see in type 2 diabetics. And there's no treatment, but it should trigger, if the patient doesn't have diabetes, you ought to think about diabetes. All right, osteolysis. And I'll just about guarantee that this has come through the clinic and we've missed it, and that me included. It typically presents with pain and erythema in the joints. They may or may not have peripheral neuropathy, and they may or may not have evidence of microvascular disease. It tends to involve the distal joints in the foot. If you x-ray them, the x-rays are normal, SED rate's normal. The x-ray will show shaggy bone ends rather than the shaft, and there are no reactive changes. And you can also see osteopenia in juxta-articular erosions. That's what you see in rheumatoid arthritis. The difference is inflammatory markers are negative. The patient doesn't have symptoms of an inflammatory arthritis like prolonged morning stiffness. Plus, the isolated involvement of the foot should tip you off that it's not RA, because typically RA also involves multiple other joints. Mechanism of injury is unknown, but you can see increased blood flow, so therefore hyperemia, diminished pain sensation, and minor trauma are likely triggers. There's no treatment. You can treat the patients supportively. You can put them in orthotics. It's important to consider this so you don't chase something else and do other testing. And I wonder how many times we see patients that come through the clinic or the ER and they're admitted for osteomyelitis and their SED rate's normal and they don't have an ulcer, and we diagnose them with osteomyelitis and hammer them with 6 weeks of vancomycin. So the next time you see a diabetic with a painful foot and it doesn't look like osteo, you need to think about this. You may save the patient some nephrons. There's another type of osteolysis that involves the larger joints. It's sudden onset. The kicker is the pain is out of proportion to physical findings. So this is a patient that when you palpate the joint line along their knee, they produce a positive chandelier sign, but you just don't see much else. It's usually monoarticular. They will often have had previous episodes. It's going to be more often in females over 50. They can actually have an infusion in their knee. And when you tap it, though, it's not inflammatory. Cell counts are low, proteins low, etc. But again, sudden onset, pain out of proportion to physical findings, prior episodes. Think about migratory osteolysis. Again, SED rate, inflammatory markers, WBC is normal. You may see focal osteopenia, so therefore, if you think about it, it might be worth x-raying the knee, maybe even x-ray the other side to see if there's like similar findings on that side. The treatment, you can always give them glucocorticoids and jack up their glucose. Calcitonin has been used, but usually this is going to go away on its own. You need to know that. Sometimes it takes 6 to 8 weeks for this to get better, and you just have to wait it out. And you have to tell the patient that. This is something that's going to go away on its own, so you don't start doing MRIs, looking for DVT, et cetera, and subject the patient to a lot of testing they don't need. Muscle infarction. Again, this is a great mimicker. It's rare. It occurs more commonly and frequently in women and type 1s. It's usually seen in patients with other complications. As a matter of fact, most of them have all three of the big three: retinopathy, nephropathy, and retinopathy. They'll come in with sudden onset of pain with swelling. Only 1 in 3 will have a palpable mass. 84% will be in the thigh and only 1% in the calf. 8% are bilateral. The CPK is only elevated in half. The SED rate is only elevated in half. So that does not help you in this case to tell you if it's positive or negative. There are multiple causes that have been proposed: microangiopathy, microvascular disease and atherosclerosis, hypercoagulable state, excessive insulin leading to hypoglycemia and hypophosphatemia, brittle control, where high blood sugar is followed by low blood sugar, but really nobody knows what causes this. Imaging, MRI with T2 weighted imaging is preferred. CPK may or may not be elevated. And again, the importance in making this diagnosis is so you don't start chasing and looking for something else like DVT. If you think somebody comes in with a painful thigh, the first thing we're going to think about is DVT. And here's an MRI that shows a muscle infarction. This is a T2 weighted image, and it's marked with arrows, and that's pretty typically what you're going to see in a muscle infarction. So if you have a young type 1 brittle diabetic with multiple other complications that comes in with acute pain in the thigh, you need to think about muscle infarctions. It's treated symptomatically. Bed rest and analgesics, they've tried multiple other things. There was one report of it been seen in patients with hypercoagulable states, but there were only 2 in one series, and that really doesn't make a series. But if you think about it, if you have a diabetic who has nephrotic range proteinuria and is leaking antithrombin 3, protein S, protein C, they're going to be hypercoagulable. The question is, does it really cause muscle infarction? And I don't think anybody knows. I put gout just because it's an uncommon complication of DKA. Think about all the DKAs we get here. We need to think about when they're transferred out of the unit. We need to watch them for gout. Uncontrolled diabetics will have increased levels of uric acid due to the fact it's competing with the glucose in the proximal tubule to get out of town. It's also seen in patients post-kidney transplant that are on cyclosporin. And again, the common factor between the two is obesity. And again, there's a link or an association between diabetes and pseudogout, but it may simply be that there are 2 common entities that become more common with aging. So there may not be a pathophysiologic pathway, but it's recommended that if you see a patient with CPPD, that you test them for diabetes, and that CPPD should be part of the differential in a diabetic that presents with joint pain, particularly in large joints, knees, especially knees, and if you see chondrocalcinosis on x-ray. Now, this is kind of where the rubber hits the road for this topic. We always think about the impact that, let's say, neuropathy, poor vision have on patients' functional capacity, their ability to function day to day and do activities of daily living. We don't think much about adding the musculoskeletal component of this. It's frightening that the majority of diabetics will be over 65 in the next 25 years. And the projection is that 30% of diabetics will be over 75. That's a lot of tottering old people with diabetes, many of which have neuropathy. And beyond the impact of aging themselves, their health will be impacted by the effect of diabetic complications, heart failure, COPD, CKD, DJD, obesity. But the one thing we don't think about is the effect of diabetes that it has directly on muscle tissue. Diabetics, type 2s, have increased fat mass, but also have increased muscle mass. So why are they so soft? Well, also the effect of diabetes on muscle quality are attenuated in women when you factor in smoking, alcohol, chronic diseases, impaired vision, and renal insufficiency. So again, you kind of have to take a kind of a systemic view of the patient to figure out why is this patient languishing. It's not true in men in this one study. Duration of diabetes over 6 years was associated with poor muscle quality. What you see in diabetics is they have increased muscle mass, they have decreased strength. So their muscles are not of good quality, they're not very efficient. And it gets worse with poor control. And adjustment for obesity only partially attenuated the difference between diabetics and non-diabetics. So you can't blame it all on obesity. There seems to be an effect of the diabetes on the muscle tissue. Now, what do we use to evaluate patients functionally? We do the 6-minute walk test, the get up and go test, and stair climbing. This study, which is in the handout or the presentation, were used to assess type 2s. It's interesting, they only picked diabetics that had duration of disease an average of 4 years, and 100 patients were studied. So low number of patients, relatively short duration of disease may have affected the outcome, but there was a marked reduction below recommendation in walking capacity. It's seen in diabetics with peripheral neuropathy, and measured diminished muscle strength was diminished 18 to 20%. Obesity reduced walking capacity by less than 1%. So there seems to be something going on in diabetics that are over and above what happens with obesity. The 6-minute walk test was impacted by obesity and decreased muscle strength and also peripheral arterial disease. That's not a surprise. The get up and walk test was impacted by obesity and decreased muscle strength. Stair climbing was impacted by BMI and fear of falling. And note that peripheral neuropathy, while affecting walking capacity, had no impact on functional capacity. This could be that patients with peripheral neuropathy only affects mobility in challenging environments, such as found in daily life. We're not testing the right thing when we do the get up and walk test and the 6-minute walk test and testing obese diabetics with peripheral neuropathy. If you think about it, how many of you have ever seen a morbidly obese patient go down steps? It's a challenge, isn't it? Sometimes I think we ought to put mattresses at the bottom to catch them when they fall. It's tough when you're morbidly obese to go down steps. Give them peripheral neuropathy and think about what that does. And this is the study that I used to look at this. So why should we think about this? Well, patient education, we need to talk to them about it early. You may not have inefficient, poor quality muscles yet, but you will if you keep doing what you're doing. You need to stress the need for weight loss, and in the rare diabetic that's not obese, weight maintenance. And we have to educate the patients on the association with muscle strength and good diabetic control. I think we probably don't refer to physical therapy enough to work with physical and occupational therapists to minimize the impact. How many of you have ever heard of vestibular therapy? You may have heard me talk about that in clinic. You know what vestibular therapy really is? It's exercises to strengthen the core muscles. That's it. It doesn't improve the patient's balance. It improves the core muscles so the patient is better able to compensate for sudden losses of balance. That's vestibular therapy. We're not training their inner ears. We're building up their core muscles and their hip girdles. And that's something that we can do for diabetics that have poor muscle quality. You also, though, have to look at the other comorbid conditions that affect patient mobility. How many of you have heard me talk about the impact that poor vision has on people with peripheral neuropathy? Throw in poor muscle quality and think about the patient's risk of falling. And we need to identify patients at risk for particular bone and joint problems in diabetics. Not just diabetic hand syndrome, et cetera, but CPPD, gout, things that they're more likely to have, and especially, I think the big one that can be the biggest problem are diabetic hand syndrome and adhesive capsulitis because they affect the upper extremities. And for the older men in the study only had a slightly higher muscle mass, whereas women had an increase of 12 to 14%, but again, their muscles were poor quality. They could not produce the hand grip and the strength testing that non-diabetics do. What causes it? Well, if you think about it, hyperglycemia is a catabolic state, which can lead to muscle protein digestion and breakdown, inadequate energy use. They have increased levels of inflammatory cytokines, tumor necrosis factor, interleukin, that can affect muscle function. And then throw in neuropathy. It's associated with decreased muscle strength with type 1 and type 2s. So if you have a patient who has poor quality muscles and you give them peripheral neuropathy, their muscles are not going to be very efficient or effective. Okay, those are the references. Anybody got any questions or comments? That's it. Thank you.